Today we're talking about pulmonary function testing and interpretation. In order to have determinant values on a pulmonary test, you need at least 3 acceptable trials and at least 2 repeatable trials. This may take several efforts on the part of your patient to get these results. Your nurse can do as many as 8 trials, should not do more than that. And on some patients that are coming in with symptoms or very severe COPD patients, they may not be able to actually meet the acceptable and repeatable trials. You're going to look at the values in your result box. The FVC is forced vital capacity. It's our best estimate in an office spirometry of total lung capacity. The FEV1 is forced expiratory volume in 1 second. It's everything your patient exhales in the first second of the test. The FEV1 FVC ratio is the correlation of the forced vital capacity and the FEV1. And then lastly, I look at the FEF 25 to 75%. This is approximately 3/4 of the way through the patient's exhalation process. And some of your COPD patients will have extremely low values in this area. The very first value I look at in interpreting the results is the FEV1 FVC ratio. This value is based on the lower limits of normal, and it determines whether or not the patient is having airflow obstruction. A normal value would be 0.70 or better. In this case, you're going to want to look at the actual value, which is 0.62, which indicates this patient has airflow obstruction. You then want to look at the FEV1, which is forced expiratory volume in 1 second, and that determines the severity of the airflow obstruction. In this case, you do want to look at the percent of predicted. This patient is at 40%. Normal value would be above 85%. Mild COPD would be greater than or equal to 80%. Moderate would be 50 to 80%. Severe would be 30 to 50%, and very severe would be under 30%. Occasionally, the computer interpretation says that it's a restrictive airflow disease. You need to be cautious when you see that interpretation, as a computer or as a office test cannot determine whether or not there's restriction of airflow, since we are not doing total lung volumes. The only way to determine restriction would be to have full pulmonary function testing done in a pulmonary lab. We're now going to look at the forms we've created in order to document our findings. The first part of the form has to do with spirometry interpretation. You'll look at the middle column of the FEV1 FVC ratio and determine where your patient falls. If you've determined that, you then go to FEV1 predicted to determine the severity. So say that your patient is less than or equal to 0.7 for their FEV1 FVC ratio, and they are at 50 to 80% for FEV1 percent predicted, they would have moderate COPD, and you would highlight that box. If for some reason your patient did not meet the acceptable and repeatable criteria, I would mark the indeterminate spirometry box. There is a place after that sentence that allows you to add a comment. You might want to say the patient met 3 acceptable trials but unable to reproduce any trials, or the patient coughed throughout all spirometry trials today. The next segment of the documentation is management. If you're going to continue the current plan of care, you're going to check that box. It's important to check when you plan to follow up with your patient, either in weeks or months. You might add to the management. This may be a new COPD patient without very many symptoms, and you may feel comfortable adding a short-acting bronchodilator. Or this may be a follow-up patient who's already been on a short-acting bronchodilator and now needs an anticholinergic like Spiriva. I did not put the combination inhaled glucosteroids in here along with the long-acting bronchodilators, more so to keep it simplified. But if I was going to put a COPD patient on Symbicort or Advair or Dulera, I would mark the inhaled glucocorticosteroid and the long-acting bronchodilator. We left a box labeled Other just because there are still some COPD patients come in that are on theophylline, or they might be on a mucolytic agent to help them with their secretions. And the last component is comparison of previous spirometry. If your patient's stable, you would mark that one. If you're having them back after giving them a prednisone burst and they're significantly improved, that would be an appropriate box. I left Other just as an alternative for any unknowns. So in finishing, in order for us to be able to for us to be able to charge for our spirometry in the office, we need to document all three components: the spirometry interpretation, our management plan, whether it's staying with the current plan or changing it, and our comparison of previous spirometry if it's available.